Hello, everyone. Welcome to our September 2025 CCO Club CE webinar. This is the one for our club members. It's about continuing education. This will have a CEU unit available soon. Give us a couple weeks. It'll be in the club. This is for club members only for the CEUs. You can certainly become a club member if you aren't one already. Hey, Alicia, how are you?
Doing good, doing real good. Getting ready for the change in weather.
Yeah. And just to let everyone know, literally, I am saying hello to her for the first time because she literally came on like now. So she was having trouble getting logged in. So
Yeah.
we haven't even had time to like kibitz like we normally do ahead of time.
Normally, we have extensive conversations before we meet up with you guys and talk about all kinds of things.
So you can let us know how we did at the end, having not done any run through. I think we're getting overly confident. I don't know.
I think you're right. Yeah.
We have such a good team. So gratitude to Mary that pulls all of the components together, and Sylvia that does all of the review, and the interns that do all of the initial legwork. And of course to Alicia for taking a big chunk of her time doing this every week. Appreciate it. So let's see, who do we got on tonight? I saw Pennsylvania.
I see a lot of new names. I'm not sure if you're catching that, but yes. And Marguerite, you don't have to put any of your information in the chat because you'll go to the club to get your CEUs. Like Laureen was saying at the beginning, that's where they'll be. But we do always like to know where you're from. That helps us feel a little more connected to you. Mm-hmm. So if you want to pop that in there, and we do appreciate that.
And I'm a Florida girl. Where are you from, Alicia?
Well, I born and raised in Missouri, lived a few other places, including Texas, but back home in Missouri. My father just moved back to our hometown, and my daughters that had been in Dallas is only 2 hours away. So my only child that is far away is my number one, and he's up north and up by Minneapolis.
Yeah, things are really different now with travel. It used to be that you just stayed in your hometown, but now everyone's so, like my stepson's all the way in California, and he has a baby now. It's like, man, we don't get to see her because we're like on the whole other side. But let's see, we got people from Alaska, another person from Florida, Arkansas, Georgia, Bermuda. How cool. Oregon.
Cleveland, Ohio. That we do, it is kind of fun. We do get people international, and then we get people from other, U.S. areas like Puerto Rico sometimes. Pop in. Cynthia's in Mexico, Missouri. I know where that is. I went to college up there.
There's a Mexico, Missouri?
Yes, there is. It's
wow.
Well, actually, I'm sorry. I didn't go to school in Mexico. I lived by Mexico, Missouri, in a vase, which looks like oxvasi. It's actually French for mud hole, which I'm sure she knows.
It's French for mud hole?
I went to school in Moberly. Huh?
Is that what it's
French for mud hole? It's AUXVASSE, and it's a tiny little town of, I don't know how many anymore, but right outside of Mexico. We used to go to the Walmart in Mexico.
Wow. So for tonight, I'm just going to do one kind of commercial slide initially, and then we'll do the rest at the end, just to keep you up to date what we're doing, answer your questions. Any questions you have, we're going to be doing 3 topics tonight. You can ask while we're presenting. So when Alicia's presenting, I'll pull the questions in for her, and she'll do that for me. So the only slide I really want to share is this one on our 2026 pricing table. I know we're still in 2025, but I kind of go by school year, so September. So I've shared this the last couple of webinars, but we have very new pricing. So I really want to make sure people understand we're having a lot of people take advantage of it. So I'm kind of excited that we made this decision. It was a big one for us. So what we've done is, if you look at this column for our courses, our main courses, which include, now it includes lifetime access if you do full pay. You pay for the whole course, not payment plan, not anything else. You get lifetime access. Before it was just 9 months. I think AAPC and schools like that, they give 6 months. So we give you 9 months to finish the course. But with this, if you do full pay, you get lifetime access. And that comes with all of our courses, no matter which method. You get group support. We do a Zoom call once a month just for our students and club members. You have private coaching. Now with the full pay students, you also get phone coaching. So you can, it's not just, coaching through a chat group. It is with us on the phone. Everyone gets access to the Bat Cave for courses and blitzes. The Bat Cave is where we show you our annotated CPT manual, our annotated ICD-10 guidelines, things like that, bonus area, test taking tips, that sort of stuff. And with the full pay, we add a blitz and practice exam in this bundle. So obviously that's the most value, but you have to come up with the most cash. So they're roughly around $1,500 for our full core courses. And for our ancillary courses, they're about half that. Our ancillary are things like medical terminology, pathophysiology, pharmacology, medical terminology. I don't know if I said that already. Our ancillary courses. Now, here's the new one, this third column here. This is our subscription model. This is the new one we've introduced. So you can subscribe to any of those $1,500 courses for $59 a month. So if you get through it in 3 months, and we've had someone do it, or the first person that signed up, she's almost done with her risk adjustment course. So and it's something that she wanted to do for a long time. She saw this and she jumped on it. We will never have sales on this subscription price. That is the price. And so you can jump in and even try it, because we have a no refund policy, because basically you get access to everything immediately. So with the subscription, as soon as you're done, you just cancel. So, I mean, you'll finish out that month, it's month to month, but then you can subscribe to the Blitz, and then you can purchase a practice exam. So you can do it very modularly, a la carte, so to speak. And then, so those are for the 2 ways to do the course. So the way I like to think about it, do you want to rent or own, right? So, and it's about budget, but this is helping a lot of people that have gotten stuck in bad courses with other schools, even very reputable ones where the lectures are very boring and they're like, I feel like I'm not learning. I have to listen to it over and over and over again. You can supplement it with our subscription. So if you're halfway through and you're like, well, I think I'm going to make the investment of $59 a month and do it for like 3 months. And so I can listen to the CCO lectures on the same topics that I'm going through and, get through the course that way. So we were trying to bridge that gap that people were having, that pain point where they were sad that they purchased a course somewhere else, wish they had, signed up with us. This is a way that they can do that. And then for the blitzes, same thing, full pay or subscription. Full pay is $200. This actually shouldn't be per month. It's just $200. And then all the subscriptions are $59, just to keep it sane for us. And then we got the practice exams. So just check that out. Go to cco.us. You can see, all these things being shown. And if you have any questions, I'm happy to answer that when we're done with the presentation. So what are we going to cover tonight? We're going to cover billing multiple bursts. That's going to be covered by Alicia. I'm going to do the second one, CPT 10120 explained. And then Alicia will finish up with coding multiple perianal destruction procedures. I was just laughing at how you got multiple births.
I know. I caught that too.
I have multiple kids and they are multiple pains in the butt. So
that'll go with the perianal destruction we'll be talking about.
There you go. All right, so let's let Alicia kick us off with multiple births and modifiers. Are you going to share, or do you want me to be Vanna White?
Why don't you be Vanna White? If
Okay.
that's okay, since you've already got the screen up, is that okay? I've got it here, but
no, that's fine. Go ahead.
All right. So, are you going to share, or do you want? I was going to have you share it. It's only showing the. Oh, I'm sorry. No, never mind. I know what I'm doing. All right. So the question, guys, that came in, and just a shout out to say how much we appreciate you submitting questions, because then we know that we're covering topics and areas that are relevant to you. So the question that had come in was, the patient delivers triplets via C-section. Delivery required extended time due to the third baby's breech position and intraoperative hemorrhage and uterine atony. I don't know is that how you say that, Laureen? Atony? I think it's atony. I could be wrong.
It is. I would say atony.
Okay. So
it's kind of like my husband's name, Anthony.
I know. That's because Laureen does say that. Okay. The key here, and I've got it on my monitor as well. I hope you guys can see that, but a special thank you for the person that submitted this, that wanted to be anonymous. And let's see. I don't think, they did, because we will not submit your name out there to the public unless you want us to. And then the answer sheet was worked on by one of our interns. So we appreciate that. If you're interested in hearing more about our internship, we'll tell you about that at the end. So getting right into the scenario. Again, what's happening is we have multiple births. Now, for OBGYN, it can be intimidating just because there's so many codes involved. But that's because we have a lot of information we need to convey, and that's what the codes do. So, one, we need to say how many babies were born, how many were live births, and then how they were born, whether it was vaginal or C-section or VBAC, which means it would be a vaginal birth after a cesarean. And then on top of that, gestational age and a bunch of other things fall into play. So the main things that we need to be informed about is that what's happening here. Well, we've broken it up. So you have 3 babies, which isn't actually that rare anymore. And we had some that were vaginally born, but one baby was breech, and they ended up doing a C-section for that little one. Now, so that changes the dynamic of the story, right? We're going to have an additional op report in there in the paperwork. And if you're not aware, there's multiple ways to have a C-section. For the most part, they do it like they're showing you in this graphic A, especially if this is a first C-section that you have. They won't go from the belly button to the pubic bone, but they'll do what they call that bikini line. The scar heals up better too. And then they open you up and the baby comes right out of the uterus. The breech presentations, there's multiple types of breech presentations. Actually, there is more than the ones that we're showing here, but the common ones are going to be complete, and then there's incomplete, and there's frank. And when you have a frank breech, notice that the little baby's legs are up by his ears and these folded in half, kind of like a taco. And what's really interesting about these babies, after they're born, their little legs go up and they flip. And so you'll pull their legs down and they flip back up like they're on a hinge. You can go out there and see that frank breech babies. Google it or see little videos, and it's really cute to see those little babies pull back. Anyway, it doesn't hurt them. They grow out of that. Now, another scenario that makes this more complex is that we have a hemorrhage, and it's not just a hemorrhage. It is for a specific reason. We have uterine atony, which it means that we have an excess of blood that fills up into the vault of the uterus. And remember, it's still distended and enlarged. So you have, that's normal. But it as soon as the baby is born, the uterus starts clamping down on itself and going back into shape. And if it doesn't do that in a timely manner, and that's another reason why they come in and massage the uterus and pressure real hard, then it will stay like a vault, and the hemorrhage will build up, and then it'll come out. It won't stop the hemorrhage, in other words, as it was normally meant to do. So let's talk about the answers. The first thing we need to be aware of is that there will be a modifier involved, but the CPT code, because that's where you're going to start, is going to be 59514. And that is for the cesarean delivery only. But we also will append on that modifier 22. And if you are not familiar with the modifiers, know that we have a fabulous modifier grid that Laureen created many years ago. And it's still relevant, but she created a way to just at a glance see how the modifier will affect reimbursement, as well as sectioning the modifiers in areas, lumping them together. So I encourage you to go out and look for our modifier grid. Maybe Laureen will have that link before we end today. But it is a free tool that we used to give out in the past, and you can laminate it and keep it at your desk, or even, give it to someone and let them know that CCO offers great education. Going back to modifier 22, when we break it all down, because there's a long description here, the important thing that we need to abstract from the description of modifier 22 is that it is increased service, intensity, or procedural time, or increased technical difficulty. Now, there's should be several reasons that this is increased difficulty, severity, intensity. One, and the main reason is because we had 3 babies. Okay. So that right there constitutes the modifier 25. But even though I didn't highlight it, I want you to be aware that as we read the rest of that sentence, it says, or physical and mental effort required, and especially severe patient condition. Whenever
Alicia,
you're going to, yes?
You said modifier 25. Did you mean 22?
I said 22, I thought. I meant
No,
to
you
say
said 25.
22.
Okay, I wanted to make that clarification. 22.
Okay, yes, no, I meant 22. And I've been looking at modifiers all day, so that could be a reason why that might have slipped out. I never heard myself say that though, but I very well could have. Whenever we're going to use modifier 22, we need to be aware that in those instances, probably the op report or what it's going to go along, be sent in. So our documentation needs to be really steady, and it needs to prove the intensity of the CPT code. Okay. So if you're on the clinical documentation side of things, or working with the clinicians, then that is something that needs to be articulated in the document, or they're not going to give you modifier 22. Now, let's talk about the ICD codes, because they're my favorite. And again, it's pretty easy to pick out the CPT code because we're doing a C-section. There's not a lot of complexity for that CPT code. The ICD code that we're going to start with is to tell the story. We need to let them know how many of the babies are arriving, and we have triplet pregnancy. So that is going to be 030.133. That's telling us when you look at that code, it's a triplet. Now, if you look at the trichondric and the trianotic, that don't worry about that because it doesn't matter. That's redundant. That just more or less means if the babies are in their own sacs, or if they're in individual sacs, placenta sacs, or if there's like two. Technically, with triplets, you could have an identical twin and you could have two identical twins and another one. So that's getting into more complexity. We've actually done some education in the past on this type of multiple births a long time ago. And it's pretty fascinating for you to go and look at that. But the other thing that this code indicates is that this was the third trimester. So if we have triplets born before the third trimester, then that would be indicated in the code itself. And if you look up 330.133, it's everything after the decimal, that 133 that tells the rest of the story in the code. Moving on, next, we have a baby that was breech, and we need to let that be reflected in the code set. And that will be 032.1XX3, maternal care for breech presentation. And that 3 at the end is telling you that it's the third fetus, the third baby now. And therefore, that has to be articulated when you have multiples. There is a possibility that depending on the scenario where you may end up having situations with different ones of the babies, and they will number them 1, 2, 3, 4, and so on. And until they are given a name, they'll be in the system as, like baby last name. So if I was having, it'd be Scott baby Scott 1, baby Scott 2, things like that. And that's how you'll make sure you're putting the right information in the right chart until the baby's given a name. Now, after that, we move on to the immediate postpartum hemorrhage that happened. And that is going to be 072.1. You're going to look this up by looking up hemorrhage, uterine. And because this says Antony, it's this very specific type. However, this 072.1 in the first part of the description is postpartum hemorrhage, not otherwise specified. But if you look at the multiple listings on how it can be described, then it does say uterine atony with hemorrhage. And so that means it would have one without hemorrhage, right? So whenever you've got an option between two things, you'll see that revealed in the code set. And a lot of times it's after the decimal that information is obtained, or how you translate that. Moving on, we're going to jump into the next code, and that's going to be our Z code. Now, some people find this a little tricky, but we always need to identify how the baby is born. And is it a stillborn or live born? So now we have a triplets that are being born. All were live born. So that's going to be Z37, and 0.51 is the code, but it's used on the mother's chart, right? So the C section is on the mother's chart. So the Z37.51 is on the mother's chart. Now, when the babies are born, then they will get their own chart. And on the infant's record, you would end up putting Z38.62, saying that this was one of a triplet and live born delivered by C-section. So you don't want to get those codes confused. So the Z37 code says that, we had triplets and they're all alive. And then when each baby is separated, then each one will get that Z code stating that they were a triplet and that everything was good, and how they were delivered, whether vaginal or cesarean section. So really, to summarize, what we're looking at is telling the whole story step by step. So on the mother's chart, remember, everything stays in the mother's chart until the baby is delivered, and then it's separated. That's kind of complex when you first start doing OBGYN. And the scenario and the codes that we've given, except for that last one, all pertains to the mother and the delivery of the babies. How many are there? There's 3. So we described that. How were they born? They were born cesarean section. And how many were there? Usually it's single live born is what typically happens. And then it breaks down into any other complications that happen within the delivery. Any complications that happen after the delivery for the baby goes on the baby's chart. But to that point, before the babies are delivered, all the information goes on the mother's chart, even if the baby has a complication in utero. And that's it for multiple births. It's an exciting area to code for. And once you get, it's kind of like a recipe. Once you get used to it, you almost get it memorized. And so it's not as difficult after you get going. So I encourage you guys to look into that if that's something you're interested in. It's a fun area.
Aren't those babies cute?
Mm-hmm.
All right. So multiple births. So now I'm going to talk about this question. It's a little apropos, and the student had a question on it, or the coder. Let me jump to that one. There we go. So this was requested by Swati Rangari, and the intern was Ranshida Kodakatai. You guys are really challenging my tongue tonight. And here's the little report. It says, the patient and I have discussed the diagnosis of foreign body in the left hand. I did take some liberty and edit this a little bit for teaching purposes. I have proposed the following treatment plan: foreign body removal. Alternative treatment options were discussed. Leave the foreign body and send it to a specialist for removal. Discuss potential benefits and risks, including but not limited to scar, bleeding, infection, and pain. The risks of refusing treatment, infection, and pain. Looks like you're going to get pain either way you go. Patient was offered the opportunity to ask questions, and no additional concerns were addressed. The patient desired treatment, and verbal informed consent was obtained. So all in that same visit, they go ahead and they go and do the procedure. So now they're describing the procedure. So the location, left hand. And be thinking of what you think the answer is, because I'm going to give you a chance to put it in the chat. So the area was prepped with betadine, anesthesia with lidocaine 1%, using sterile technique, 3 millimeter incision. There was 3 millimeter incisions made, and there were 3 foreign bodies removed. One was 2 millimeter, one was 3 millimeter, and one was 4 millimeter. So the question we're trying to figure out, are we reporting per incision, per foreign body, or per something else? What are we doing here? Goes on to say, sterile dressing applied, no additional foreign body noted. The patient tolerated the procedure well. Wound care instructions were given, and the patient was instructed to return for redness, warmth, or swelling of the skin, red streaking, pus, increasing pain, fevers, or any other signs or symptoms of infection. So this is the person's question. She says, now I have some questions in my mind. Would this be coded 10120 times 2? And I put the codes here. So 10120 is incision and removal of foreign body, subcutaneous tissue, simple, versus 121, which is complicated. So her question is, she's already thinking it's a 10120, a simple. She says, is it times 2 per incision or times 3 per foreign body? Or is it 10121, which is the complicated one? Only considering the requirement of multiple incisions is complicated. Which one would be correct? So take a minute. What do you say it is? Is it A, B, C, or D? A is the simple times 1. B is the simple times 2. C is the simple times 3. And D is the complicated. So let me see some letters coming in the chat here before I move on. Come on, guys. Don't be shy. How many people we got on here? We got 60 people. Are you seeing answers, Alicia? Maybe I have to tell them the winner gets a prize. All right, I'm going to move on here. So we got to look at the guidelines because the definition is simple versus complicated. That's not really giving us a lot to go on. And it says incision and removal of foreign body. So in this case, we had 2 incisions and we had 3 foreign bodies. So what's our unit of measure? Okay, now they're coming in. I see a C, an A, a C, a B. Okay, I'm not going to say names. So the key question is, what is this billed per? Here's the CPT assistant that I found. This is May 2018. And there's an ambulatory surgical coding reference as well in 2024, which says CPT 10120 is only billed more than once if the foreign bodies are removed from different wounds, not multiple incisions or multiple foreign bodies from one wound. So that's where the unit of measure. So if you were marking up your CPT book doing the BAT method, I would have you write per wound. And so this is apparently shards of glass were in the left hand. So they're dealing with the left hand. The hand isn't very big, obviously. Now, if you had the left arm, they could be dealing with something up by the shoulder and then some work down by the elbow. You could argue that those are distinct sites. Even though they're both on the arm, they're distinct sites on the arm. But the left hand, and you're picking out glass, they're going to treat that as one. And it's simple, it's very much on the surface. There was nothing in that little blip, that little report saying it was complicated or they had to do, anything like that. So that's the guidance. It's per wound. Going on in the next bullet, per the AMA guidelines, if multiple foreign bodies are removed from the same incision or wound, report 10120 once. If multiple wounds or sites exist, report additional units with a modifier like 59 or XS and all that other Medicare type ones. So here's some further guidance for you. CPT 10120 is reported per wound, not per foreign body or even per incision. If multiple foreign bodies are removed through a single incision, you report 10120 only once. If multiple incisions are made to remove foreign bodies, you may report for each incision, but it's only if they were distinct, like if they're real near each other. And it's the same with doing, stitches. Sometimes you have a gap between stitches, but someone gets 10 stitches and they're not totally connected like you're sewing on a, garment, but they're close enough that they treat it and you do the length of the wound that way. 10121 is used for complicated removals, and there's more down at the end of this answer sheet where we'll go into that. But basically, it requires extensive dissection, deeper tissues, more time and effort. So for this scenario, there was 2 3mm incisions were made and 3 foreign bodies were removed from the left hand. So the correct coding, if each incision was made at separate sites to remove a different foreign body, then we could report it times 3 with the modifier. If both foreign bodies were removed through a single incision, you would report 10120 only once. So, and 10121 would only be used if the removal was complicated. So again, the key points, we're being a little redundant here, but do not code per foreign body or per incision, code per wound. Use modifier 59 for additional incisions at separate sites, and only use 10121 for complicated removals. And when you go into the club and you get access to this answer sheet, you can look at these references here. And then we went on to understanding when multiple incisions constitute a complex foreign body removal. So it's defined by more than the incisions alone. Multiple incisions do not automatically mean the procedure is complex. Complexity is determined by these bulleted factors here. The depth of the foreign body, like if it's embedded, like you start seeing them talk about muscle or fascia, you know that's pretty deep. Or if it's near vital structures. The extent of the dissection or exploration, the use of advanced techniques, like maybe they needed fluoroscopy. You know if they're bringing imaging in, it's deep. Time and effort involved, if they talk about extensive time, and because some wounds can have lots of little bits and pieces, and it becomes very time consuming, very tedious. And then maybe there's already infection that started in, you got pus or necrotic tissue, so that would complicate it as well. So that's when you would use the 121. And this is just an image that the intern found. So you can see this sewing needle is embedded, and they got to make an incision, and they got to go in and pull it out. So it says a sewing needle completely embedded below the surface is easily located with the radiograph after the application of local anesthesia, small incision. So yeah, so this one's a little more complicated than picking out glass, just below the skin. And then this one here, they make an initial incision. It says if a linear skin incision is used to locate a mobile foreign body, so it's moving around, that is perpendicular to the skin. So here, this like needle or pokey thing is going straight down instead of at an angle like this one. And they had to make a modified elliptical incision to be able to open it up and visualize it and get in there and get it out. So that becomes more complicated. It wasn't a simple little, pluck it out sort of thing. And so you can see now this one, they're taking a big chunk of skin out along with the foreign body. So now this all has to be closed up, and so that makes it a little more complicated. So a surgeon may make multiple incisions to remove foreign bodies located in different anatomical sites or depth. If these incisions are straightforward and the removal is simple, the procedure may still be coded as simple. So basically, as you become more experienced at coding, you just get a feel when you're reading it. Like if you had to pay for it, does it sound like a simple or does it sound like a complex? Because you can kind of tell. Here's some more language. Extensive exploration or dissection, deeply embedded, you'd see language like that, or deeper structures like muscle. The procedure involves significant time. So again, the physician needs to document that. If it was really extensive, then you want to see some extensive language evidence in the report. So when it comes to billing, if multiple incisions are made at distinct sites, then you can code each of those sites. You need good, clear documentation. Like if fluoroscopy was used, then it needs to be documented within the procedure note area to have the better chances of that getting coded correctly. Here's another case study where a patient had an abscess and a retained foreign body in different locations. 2 incisions were made. One was to do an IND of the abscess, and another was for the foreign body removal. So those are 2 different sites, incisions. We have a nice little summary table here. multiple incisions, simple subcutaneous removal, multiple CPT codes, and I underlined if distinct. Got to keep reminding yourself of that. If it's distinct areas, if it's just the left hand and it's all right there together, it's just going to be ×1. Multiple incisions with advanced techniques. Now you're going to get into, maybe having to code for the fluoroscopy separately and all of that good stuff. Key takeaways: multiple incisions alone do not define complexity. That's what our original questioner was thinking, like, oh, because there's so many, maybe it's a complex. No, it's still simple. You just need to figure out how many different wound sites, and if they're distinct from each other, that's your unit of measure. Complexity depends on depth, effort, and clinical factors, and proper documentation of each incision. That's another helpful aid. If you have a nice little blurb about incision 1 and all the work there, and now I moved on to this other location and did X, Y, and Z, that really helps illustrate the distinctive areas and supports the use of, modifier 59 or XS, etc. So that was it for this one. I don't think we've got any questions. So the answer is A, 10120 × 1. So good job for those that picked A. And if you didn't, now hopefully you understand why, and it'll make you a better coder for this area.
Jean, can you hear me okay?
I can hear you.
Okay, Gina had a question, and I think you may have answered it, but I wanted to save it till the end. Are they picking out of the laceration, or do they have to make an incision? And I had put a note that, in these scenarios, there isn't a laceration and they're picking glass out. There's glass in the hand and they're having to go in and find it.
Yeah. So it says, using sterile technique, a 3mm incisions were made ×2. And in those 2 incisions, they pulled out 3 shards of glass. That's basically what they did.
Okay.
And whether the incision's there or not, it's still the wound that we're looking at now. So if there's a wound and you just start going in, because sometimes they have to enlarge the wound to get in and search and, pull out the pieces. That's why when you start to see fluoroscopy brought in, it's because they're really trying to, find exactly where the foreign bodies are to go in and get them out.
And I know what you're thinking, because our brain automatically goes, oh, broken glass would be a laceration. No, this is more of a scenario like you fell into something and the glass shattered and pieces went out everywhere. Yeah, instead of, oh, you just cut yourself on a piece of glass.
Very good. All right, you're back up. Coding for multiple perianal destruction procedures.
Well, moving on with more multiples, the question had come in that what if a provider performed perianal excisions of a condyloma and some of the condylomas are also laser ablated? How to also code if some condylomas are fulgurated and others are excised. So here's the scenario that we've got here. And thank you for Nadine to submit this question. And our intern, Kristen Estes, thank you again for doing the hard work on here. She found some great lab pictures of what a condyloma looks like. So again, the main gist of our question is that we have condylomas, which, if you weren't aware, is a type of wart, commonly seen in genital warts, and so they need to be removed. And there's multiple ways to remove them. Sometimes if they are not too deep, because not only do they grow out, but they have roots and they grow in under the skin. And if they can just fulgurate them, which means more or less lasering them off or burning them off. And fulguration, you'll see a lot of times also in ops, because like say they're going to do fallopian tubes and they or sever something internally, they'll fulgurate or laser that to not only stop bleeding, but to break that tissue in half and kind of seal it at the same time. So it's commonly done. It done with heat or like a laser thing. Dr. Pimple Popper, she uses that a lot when she's doing procedures on a big area, removing something. So the confusion is here. If we know what we're removing, so that's easy to code out, the ICD. But what do we do when we have two different methods that we're using to remove them? And again, there was a great picture here of what one looked like under a slide. So if you're going to do perianal excisions of condylomas, first we need to know where they're being removed from. And again, they can do all laser ablations, fulgurations, they can scalpel them off. There's different things they can do, but it's really important that we look at the guidelines and the documentation's what we follow. So the first thing is if they're going to excise them, they're going to be a code range between 11400 through 11446. And that's going to be for excision of benign lesions, because that's what this is. It's a benign lesion. And also when they excise, they're doing full thickness removal through the dermis. They go out and they get the margins and the simple enclosure. Usually, even if it's just a stitch, that's all included. You don't bill separately for that. That's bundled in. Now, each lesion should be reported separately. So measure the greatest diameter of the lesion plus the margins if they end up doing the excision that way for the complete total to determine the appropriate code, because when you're dealing with 11400 through 11446, that size is going to be important, and it will be documented for you. You don't have to do any math. They'll have totaled it. That's common practice for them to have do that. That's part of their documentation practice. But if they do a laser ablation and fulguration, which again, one in the same thing, then you're going to be looking at a different set of codes in a completely different area. This is going to be 56501 and 56515. And those are destructions of lesions. So we're not excising and removing, cutting away. We're actually destroying the tissue itself. Now, keep in mind that if we're destroying the tissue, we're not going to be sending anything off for biopsy. Very unlikely. So not only because of where the location is or what they think it is or might think it is, would determine and how many, if they're going to use excision versus fulguration. So they could be taking some and sending them off for biopsy to confirm that they're chondromas and not something else like a skin tag, and or even something that may come back that isn't benign, that might be a malignant lesion of some kind. But if they're destroying it, say they know what it is and they're just going to get rid of them, technically they're burning them off, then you have the 56501 and 56515. Remember, one of the advantages of this is that it kind of cauterizes the tissue. So you're very seldom going to have to do any stitches or anything. They might send a salve or something to put on it for that burn. Now, when you're doing a destruction, though, they're categorized differently. It's not the size and diameter of the lesion that you're removing. Instead, we're going to decide, is it simple or is it extensive? And the way they determine that is complexity or number of lesions. So if there's one, then that's going to be simple. If it's multiple, say there's pen that they have to work out, or a large area surface that is spread out, that makes a difference. And again, if it's these codes can also be used for different parts of the body. If it's it might be more complex due to maybe the patient has some comorbidities that would make it more complex, or just the size or the area is very difficult to get to. These can get really, really large, by the way. And so we're not talking about just like something you might find on your finger or your foot. These can actually get pretty massive, extensive if left untreated. Now, you also need to be aware that there's modifiers involved. So remember, we had that free modifier grid that you want to tap into. You're going to look into using modifier 59 if it's a distinct procedure service with multiple procedures being performed on the same day. And the only way you would do 59 is if it's distinct and separate. So if we do excision, but we also do fulguration, that's two distinct procedures being done by the same clinician on the same day. Modifier 51 is when you're doing multiple procedures, same thing, same provider, same session. Okay. For our documentation, we want to be very aware of the documentation. And one of the areas that some coders, especially when you're new, you may not realize that, you have to build that relationship with the physician, because you're translating their documentation and you want to feel comfortable querying them, or if you have a question, or for them to tell you how they're going to document maybe a new procedure being done. So it's important that if they're not giving you the documentation you need to translate properly, that's where we want to make sure we're aware what's needed. Ensure that your clinicians and providers document support that for the necessity of using both codes and a modifier. It should clearly indicate the number of lesions treated. That's a given, and usually they're pretty good about that. If there's, how was it done? Excision, laser ablation, fulguration. We need to know all of that and the complexity of the procedure. So if it was more complex because the patient was on an anticoagulant, and we had to take bleeding precautions or something, then again, that would be pertinent. And whenever we do a destruction, like I mentioned before, it's not typically going to be sent off to pathology, because that's why it's called a destruction. We're destroying the tissue. There's nothing to send off. They can't look at burned tissue and little pieces of burned flesh to figure out what it is. So ultimately, again, it's all about the documentation, making sure that you have all the information you need. And yes, they can be done at the same time. And if there is, then you would append the proper modifier. That's it.
Where am I?
Wow, look what we did. Look at the time. We are so good. I was just looking to see if any questions came through. On my end, Laureen is frozen. I suspect that's not it. You know what, Lisa, we really appreciate that. You saying that these sessions are good. And that's a little reminder that if in fact there's a question that you have, not only do you have the support of the CCO Academy, but you also can submit your questions to us and we'll do the research and break them out for you. We want to teach you to be able to do this, because as a coder, you're going to be responsible for educating your clinician in, the language of the code set, as well as them educating you and on the different procedures and the diagnoses that they're involved with. But in addition, you may want to be a chapter officer sometime or do public speaking. All of that would make you look really good in your work environment if you take the lead role of researching. So this gives you some insight on how to do that for your team. Maybe if you guys have huddles, you can come together and tell them about a disease process and why it makes a difference in the codes that are used. Welcome back, Laureen.
Yeah, I was so weird. I tried to add myself back and I couldn't. I'm like, okay, I don't want to leave, then I'll disconnect us all. So I opened up a new one and fortunately
that was smart. That was good thinking. Oh, well, see, usually it's me, guys, right? My computer would freeze up or have technical difficulty. It's never Laureen, so that's new.
No, it happens, but that was a very nice compliment. Thank you for that. There's one question that came from mine. She was asking, let me see if I can find her. Very active tonight, guys. Thank you.
Yeah, we really appreciate that. While she's looking that up, I might add just a little tidbit. We've been doing this for a very long time. Laureen's been doing it since 99, but probably before that. And we work by word of mouth. So if these webinars are beneficial to you, we do one every Thursday, different types, but on Thursdays, just mark that down for CCO night. Tell others and let them know, because we can't afford to do the big advertising that some of these entities are able to do.
Yes, for sure. So Ruby had asked with the other question about the removing of the glass pieces, removal of the foreign body, is an E&M code also billable? That scenario that we read, I didn't see a significant and separate E&M. So you want to picture with procedures, if they're just having that procedure done, then you wouldn't bill the E&M. Now there was a little bit in the beginning, so you'd have to gauge it. See, this is more of a scenario that I think someone was provided versus a full report. So with what I read, it did kind of read like an E&M, but it probably isn't going to be a very high level one. And so you want to make sure that it's actually recommended by consultants that you have a very separate E&M note and a separate procedure note. Mm-hmm. Obviously, not all providers do that. So when you do have the procedure note area, make sure it's very kind of capsulized, so it's very clear that you're coding for that blurb, and then the E&M is a different blurb. And you just have to do your normal E&M calculations. Now it's based on medical decision making and see if that fits. So if it does, then you would need to put a modifier 25 on it. So I think with that scenario, I could argue it either way. It kind of seemed very minimal. But because the decision was also made that day, like it wasn't like the patient was scheduled for the removal, although that's probably what they figured. You're not going to go in with glass and leave with glass, hopefully. But that was one of the options that he was giving the patient, that they could go to a specialist or whatever. So I think you could have done an E&M with that, with the modifier 25. So just remember significant and separate. If the E&M, I think that was kind of the theme tonight. We talked about, and even with your perianal destructions. So, and then I wanted to say on Alicia's last topic with the modifiers 59 versus 51, that's just an area that I've taught on since the beginning, was modifiers. And in that, the freebie link that I gave you, if you guys go there, down toward the bottom is the modifier grid that you can request and get the PDF of. And what I did is, when I was first teaching it, most instructors will teach just how the modifiers appear in Appendix A of the CPT book. But I started to notice the pattern, like, oh, these modifiers tend to have to do with bundling issues, and these are E&M only ones, and these are anesthesia only. So with the 59, think of it as an unbundling modifier. So if things are typically bundled together, but you're trying to tell the story, no, I know this looks like it's bundled, but it's separate sites. It's separate this, it's separate that. That's what 59 is for. Without it, it would be considered you're unbundling. Whereas 51, you have two procedures that aren't typically bundled, but they're done at the same time. So it's kind of like a multiple procedure discount, if you will. So you always want to, report your most expensive one or your highest RVU one first, and then the lesser one next, because that's going to get reduced normally 50%. So, and there was talk of just doing away with modifier 51, because believe me, the payers, if they see multiple procedures, they're going to reduce it whether or not you put the modifier on. So that's a little more extra on the two modifiers there. Any other questions?
We have some great kudos that I popped up there while you were talking too.
Yeah.
Thank you guys for your kind words. And again, don't forget to let us know, because as I joke, if you guys let us pick and I get to pick, it'll always be disease process and ICD. But today I ventured into CPT a little bit, didn't I?
I want to bring the slide deck up again, but I forgot I'm on a different screen. So let me see here.
I can see the screen. Yeah, on the other screen, it looks like it came up, but it's hidden.
Can you pull it in? Can you add it?
Let's see. It says remove.
Okay.
Oh, wait, full screen layout. I can. I did it.
Yay!
I did it. I feel like my grandson. I did it. I did it.
Now you got to add our heads. Okay. So this is the part where we just kind of go over. We already talked about the club. Some people were asking, do I get the handouts? Our club members do. We show them on the screen, but we give a lot away for free. But if you want the goodies, the extras, come join the club. It's $25 a month. Or I'm going to show you a slide coming up. It's like $24.99 per month, cancel anytime. Or you could do the annual club, which is $249, but we have that on special. So hang on for the next slide. And then we have the CCO Club. Lately, a lot of people have been choosing this because for that 2026 pricing change, we now offer 2 courses plus a club membership. So to get into that, it's $329, then it's $99 a month. You get 2 courses. So maybe you want to do the PBC and medical terminology, or you want to do risk adjustment and what's the one that you like to go with that? The pharmacology,
pathophysiology,
right?
pharmacology.
Yeah. And so you can do 2 at the same time. And, when you're done with your course and you want to take a third one, complete it, you can take a third one, 2 at a time. So, but once you complete it, it's considered available for as long as you're a club member. You get continued access. So you could take all of the courses in the academy, and when you're all done learning, you can say, okay, I'm gonna stop the $99 a month, and I'm just going to do the annual. And so the annual will extend all of your courses that were not lifetime, basically, in essence, for a lifetime, as long as you're a club member. And the reason we offer that in the beginning is we need the support of the recurring, memberships. So we reward you by giving you more. So right now we have, if you go to cco.us/club, you'll see the 3 payment options. The $199 is the price for the annual instead of $249, which basically makes it less than $17 a month for the club. So, and if you're currently a monthly club member and you want to upgrade to an annual, just reach out to the help desk and they'll help you do that. So I wanted to let you know about that. I don't see any questions. Okay. Just letting you know about the YouTube channel. If you're watching from YouTube, please give it a thumbs up. Please put a comment in. All the stuff. Like and subscribe. That helps that. And my son, my 20-year-old, is doing the YouTube graphics and stuff like that. So he loves it. He goes, hey, do you see how many views you got on this? And so that will really help. And of course, sharing it in your social networks would be greatly appreciated. And it's actually just at CCO. It was CCO-Academy, but we got it even shorter. So just simply youtube.com/@CCO. Pretty cool.
So Adia said she's currently doing coding for hospitalists, and this was a great refresher. Thank you. If you guys want a specialty like that, let us know. We both are involved in that as well.
Yeah. And any topics you saw, we take topics from our club members first. But if you're a community member, go ahead and fill out the topic request form at cco.us. And, we're happy to develop it. The interns, we just onboarded, I think, 5 new interns. So they're hungry for projects to do. So give us topic requests and they'll go research it, pull it in, get some nice graphics like you saw tonight. So this is our lineup every Thursday. So the first Thursday we do the Academy podcast. We like to do interviews. If you are willing to be interviewed about, even if you're a brand new person, why are you interested in coding or billing? What got you interested? People love to hear these stories. If you're in the middle of your coursework, how's it going? What are your plans? What are your fears about taking the exam? We can talk it out, right? So just raise your hand if you're willing to be interviewed on our podcast. Then the second Thursday, we do our community Q&A. Today was more of a kind of a Q&A where we did 3 topics. And then the club CE webinar, continuing education webinar, is what we did tonight. Typically, we do 1 topic like for the whole presentation, but we didn't really have one. So we decided to just do 3 smaller ones. So it worked out fine. And so that's our lineup. And then we do the third Thursday is our student and club support call. So that's where it's like a Zoom. We get more face-to-face. You can ask us questions verbally. They're normally a smaller, intimate group. You can bring whatever chapter you're working on in your coding course. Even if you're taking a course somewhere else and you're a club member, you can join that call and say, look, I am struggling with these lesion removals. Could you please help me to understand it? And we could reteach that topic or whatever. They normally end up being very, very good. And we totally don't have anything prepared. It's just whatever you ask us, we're there to help. And if we don't have anything, we normally figure out something to talk about. So come join us. We are launching an affiliate program. If you have a following, this isn't just for anybody to go spam the AAPC Facebook groups and stuff like that. But if you have a following and you would like to, market our courses, our blitzes, our practice exams, our club to your audience, let us know. And you can just go and schedule a call with me and we can talk about it. And if you know of anyone you think we should partner with, let us know. Because the way we view it is, we have friendly competitors out there. And we all want the students to have the best, what am I trying to say? The best experience. So maybe our Blitz videos can supplement another instructor. As a matter of fact, our coach, Darcy, she teaches at a college here in Florida, but she also helps support our students. And what she does is she got her college to buy a block of Blitz access for her students, and they treat it like a book purchase. So, there's things like that to, supplement. At any rate, that's our Academy one. And then if you haven't done it, please check out the new platform, CCO.Academy. You might have to do www.cco.academy, but it's awesome. It's modern, it's slick, it's responsive, it's mobile. You can easily use it on your phone or your tablet. So check it out. And if you need any help, getting around, just reach out to the help desk. They'll direct you to the videos we've already made on it, but it's pretty user friendly. This is the slide where, in doing welcome calls with students, they were saying that they were, they had paid $1,500 at another school and they were so disappointed, but they then they found us because they went on YouTube to try and supplement their learning, and then they found us. So please, if you know of anyone who's struggling, send them to us. They can schedule a call with me. I'll help them figure out their best plan forward, and not to, they don't have to throw away their other course, but how can we patch it up? How can we fill in some of the gaps so that they can feel the most confident when they go to take their certification exam and when they go out and get their first job? So that's why we introduced that subscription plan, $59 a month. That's, yes, it's additional money. You already paid some money, but it's a great Band-Aid approach. We wish you had found us first, and, but we still want to see you succeed. And we feel that our blitzes are really, really good, and our bat cave and all that other stuff, and our test taking tips and access to us. The way we do it in this new platform, each student gets their own private group with all of the coaches and the help desk team. So, and we love to celebrate. Yay, you got a 96 on that. You're rocking it. I can't believe we just took a test. Like, we really care about you as an individual. You're not just a number. So support is what we really strive to do well. And that's what we're told. That's what we hear when we look at, other schools. Their biggest complaint is the support is really poor, non-existent. You feel like they don't care. It's not that way with us. This is just more about what I would go over with you on the call, how to transfer, any discount pricing we can help you with, etc. And then this one is just, if you go to cco.us/topic-request, that's the form where you can put in an op report, redacted, of course, no patient information. You can just put in, hey, I'm struggling with this. Could you do an answer sheet on this topic? Or we're having this discussion at work and the provider says to code it this way and I say to code it that way. Anything like that, we will develop and we'll present on one of these Thursday night calls. So that's all I had. Do we have any other questions or thoughts? Or
I've been putting them up as we go, as I see them up on the screen, and it's
yeah, come say hello to us. Come introduce yourself at the Academy. It's really developing into a nice, warm community. And we've got people that are going and taking courses at other schools, and we're all supporting each other and sharing resources. And, oh, the best thing I think is we have a Cody bot. The Cody bot is awesome. And we've trained the Cody bot on everything in the Academy. The students are having a ball with it. I make sure every welcome call I do, I make sure they know how to access the Cody bot, how to talk to the Cody bot. You don't just give it one word like lesion repair, although it probably would do okay with it. But you want to say, I just finished chapter 2 of the physician-based coding course, and Alicia said this or Laureen said that. I'm a little confused. Could you clarify? Could you reteach the topic? And let it do it. Or, this is a new one I've been telling the students, you could say, I just finished chapter 2 of the physician-based coding course on whatever it is, like integumentary coding. Could you give me some quiz questions to test my knowledge? And that's been working out good. I just have this back and forth kind of conversation. So check it out. That's only for the premium members. That means club members and students get access to the Cody bot. And what's awesome, maybe you sign up for the risk adjustment course, but the Cody bot will find answers from the ICD-10 course or from the PBC course or a blitz or even a club topic that we've developed and put into the club area. You'll still get the summary of it all, even though you're only in the one course. So that's a really great premium benefit that was way beyond what we even thought it would be. So we're very excited about it.
Katerina wants to know how I'd like to take this to pass my CRC. How do I, where can I sign up?
Sure. You can go to cco.us and you'll see well, let me pull it up real quick since I'm here. Okay. So when you go to cco.us, we have it divided with the core courses. So when you hover, it'll show you the PBC, FBC, etc. So here, this one's risk adjustment. So I'm going to click on that. And we believe in nice long sales pages. So we put everything in here that it covers, like any question you could possibly have is in here. And if it's not, or something doesn't make sense to you, then reach out to the help desk and they'll clarify. But you just come here and you got to scroll down to the bottom. And we have the pricing table here. So it's rent or own, $59 a month or the $14.47. For the subscription, you just get the course and access to the Batcave. With the full payment, you get the course, the blitz, practice exam, phone support, so you get more bells and whistles. But if you're on a budget or you just want to supplement something you're doing, then, or even if you just want to check us out, 59 is your, the most you would lose. If oh, this is terrible. Okay, you lost $59. You didn't lose $1,500. So, did that answer the question?
I think so. Yeah.
All righty. And that's true for all the courses. And you can see if you go down here, we have the frequently asked questions. Someone was asking about lifetime access. So lifetime is defined as the life of the product, service, or company. If on a payment plan, then lifetime access is granted upon final payment. No lifetime access is granted to monthly subscribers. But there's still a path where you can get continued access. You become an annual club member if you finish a course. So if you sign up for the risk adjustment at 59, you only do it 1 month and you didn't finish it, and then you become an annual club member, you don't get access to that. If you completed it, which means you took every module exam and you got over a 70%, then you're considered completed. You'll get a certificate that you completed the course. Then whenever you are extension eligible, which means you're an annual club member, then you can continue to have access to it. So as we update lectures and add maybe more handouts or things, you have access to it. Or if you just want to go refresh yourself, because now that you're actually in the job, now you want to go back and review what Alicia was talking about that in that lecture on risk adjustment or whatever. So, all righty. Well, thank you everyone for your great attention, and hopefully we'll see you. What are we doing next Thursday? I think that's our.
Is that a podcast?
Maybe I got to put my calendar up. Hang on. That's the first. Oh wow, that'll be October 2nd already. Yeah, so that's the first Thursday. So you're right. That'll be the podcast one. So anyone want to be interviewed, let us know.
Yeah.
All right. Thanks, everyone. Have a good week. Talk to you soon.
Bye-bye.
Looking for medical coding, medical billing, and risk adjustment education? Learn more at cco.us.